Welcome to The Thriving Mama, the podcast that teaches you not just how to survive, but to thrive in motherhood. I'm your host, Dr. Stephanie Davis. Two of the most common issues women bring up in their late 30s and early 40s in my practice is that they gain weight seemingly out of nowhere and the inability to get that weight off. The truth is that we are hormonally and metabolically changing during this time, and we have less what we term metabolic flexibility. So your body just doesn't have that agility that it used to have when, to kind of switch gears into like carb burning or fat burning, or, to be able to take some of the insults that it used to if you had, a crazy weekend or something of that nature. Increasing this metabolic flexibility and resilience is the key to having a healthy body composition, hormone and mood health, and longevity as we age. But how do we do this? Muscle. Muscle is the key. Today, I'm talking with my friend, Dr. Maren, who is a women's health expert in perimenopause and menopause. We're going to dive deeply into all aspects of this topic, ranging from diet and weight training all the way to hormones and microdosing GLP-1s like semaglutide. Some of the highlights include why muscle is essential to having optimal hormone balance, body composition, and vitality in your 30s and 40s and beyond, what labs and metrics you can track to both identify underlying issues and progress on your journey, and why low calories and fasting might not be your friend during this stage of life. Dr. Maren is a board-certified physician and the founder of a virtual functional medicine practice in Colorado, Michigan, and Texas. Her practice specializes in women's health and hormones, specifically perimenopause, menopause, and preconception health. She is a compassionate clinician, speaker, and wellness advocate. If you're confused about where to start on your own health journey, I'm offering podcast listeners a free health check-in where I'll evaluate your physical, mental, and emotional health and provide you with useful resources to help you on your journey. You will find that link in the show notes. Hey, everyone. I'm here with my friend, Dr. Maren, who is a hormone goddess. She is so brilliant at all of the things that she does. And one of her newer components is talking about body composition and just being strong and vibrant in your, kind of second half of life, perimenopause, menopause, and beyond. And so I've wanted to have her on for a while, and I'm so glad you're here.
I'm so glad to be here. I'm so glad to catch up with you too. It's been a while.
I know. It had been a while, so it was so good to talk. So what I wanted you to do first is kind of talk to people about your journey to how you got here, because it's not like for most of us, you just kind of like wake up one morning and you're like, something's not right. And a lot of us ignore the signs building up. So if you could kind of share what that looked like for you, I would love that.
Yeah. I mean, I got 44 years to cover here, so I'll just make it really fast and tell you. I mean, I was pretty healthy when I was younger, into probably like around med school, started having digestive issues, some hormone issues. Pregnancy sort of uncovered a lot of things, as it tends to in women. It's like a stress test for us. I had gestational diabetes. I had recurrent miscarriage, and really started taking my health seriously after pregnancy loss, and, throw some mold exposure in there and Hashimoto's and, all the things. Fast forward to where I am today. My health is much better, but I'm also 44 and started experiencing symptoms of perimenopause several years ago. And also with that, like 5 pounds or 10 pounds or whatever the annoying thing is that I just didn't want anymore because I didn't fit into my clothes and I didn't feel super awesome. But it was like, was I overweight? No. Did I want to buy new jeans? Also, no. And it was frustrating because all the things I did the things I used to do didn't work anymore. So I really sort of started that journey. And, as things go, like our personal interests coincide with what we see professionally. And I see a lot of women in the perimenopause and menopause timeframe, and really started diving into like HRT and, so right now I'm just on this journey of like helping women feel really vibrant and alive and beautiful and confident and sexy and metabolically healthy. And I love it. It's just my new favorite thing to talk about.
No, I love that because like we talked about before, so much of the messaging throughout a woman's life, let's be honest, like we are given messages that we need to act a certain way or look a certain way. but it really ramps up in those like perimenopause to menopause years. You're constantly told that, oh, you're wrinkly. Your body isn't shaped the right way. All of these things, all of the get ready for swimsuit season. There's so much messaging out there. And
so
I really
much. Yeah.
I want to flip that script. And I feel like the work that we do, but especially like you're focusing on right now, is really hitting that head on, which I really, really appreciate it, because that messaging is so destructive and it makes women feel less than and invisible. And, like we said before, we don't want to look like Twiggy in the latter half of life. And muscle, we talk about muscle. Muscle is the organ of longevity and vitality. And I feel like that's a reasonably new concept. So if you could explain what that actually means, I think that would, kind of clear the air for a lot of people.
Yeah. I want to back up because I think this weight loss conversation, first of all, it's not about weight loss. That's just what we call it because everybody's familiar with it. It's about losing fat and gaining muscle. And that is, like you just said, muscle's an organ of longevity. Like we need more of it. It helps us stay young and able and fit and do the things we want to do. It also, surprisingly, one of the side effects for me, gaining a lot of muscle in my legs, I used to struggle with IT band friction syndrome, which was like my legs were always like super tight and achy. And now like I have stronger glutes and stronger quads and my musculoskeletal system is different. I mean, I'm married to an orthopedic surgeon. Like we had this conversation last night and he's like, no, it's because your patella tracks differently, like all of these things. I mean, I'm not rolling out my IT band anymore. So point is, it just helps with some of like the body structural issues. But this conversation about weight loss, I have shied away from for years because I hate the message that women are supposed to look a certain way or be a certain way. I love the message that you, be more of who you are and do more of what makes you feel beautiful and confident and vibrant. And most importantly, like show up for yourself. Show up for yourself in the way that, I mean, I wasn't showing up for myself in the way I thought I was. So for so many years, I mean, I literally had a therapy session about this because I hired a trainer and she wanted me to track my protein and weigh my protein on a scale. And I'm like, that sounds like way too high maintenance for me. And so I had to unpack a lot with that. Like it really gets into like unpacking mindset around this, And so for women who have disordered eating, of which I see a ton, I don't recommend doing that probably, but for me, I was like, well, I don't have disordered eating. I'm not really going to get an eating disorder in my 40s. And, as my therapist said, what if you just allow yourself? Like, what if you just let yourself do that? What's going to happen? And I'm like, well, all right. Like I realized for me, I was like, oh yeah, I've like been really conditioned to think I have to be low maintenance and be highly capable and take care of everybody else, but I might not be able to take care of myself. It's just, there's a lot around that and everybody's going to be different, right? Like, I don't know what everybody else feels, but that's what was going on for me. And that's why I couldn't really get serious about like, hey, I'm going to the gym. Like, I'm sorry that, you're going to have to miss your ride or whatever, like whatever it is. I figured out a way to show up for myself so I could consistently do the things I wanted to do to reach my goals. But really, like when I'm at the gym and working hard, my mantra is like self-respect. Like last rep, it's self-respect. This is not being hard on yourself. This is not like, oh, keep going. Don't be such a, like whatever it is. It's just, it really has an undertone. Like the mindset piece, I think is critical. So
it's huge. You're right. 100%. That's like in the program that I do with, cause I focus on moms of all kinds. It's not like we're just targeting hormones or anything, but that is it. I start off the program with intention and mindset because that's what needs to change in order for the changes to occur and all the positive things to happen. Because we tell ourselves so many different stories, like you said, I need to be low maintenance. You know what? You do not need to be low maintenance. You need to take care of yourself. And that's a concept that so many women can't grasp anymore because they've always put themselves, that's the one thing I always said, like you put yourself in the back seat for too long. You need to put yourself in the front seat and take care of yourself. Awesome. So now that we've covered that part, do you want to talk about muscle as an organ of longevity and vitality and just, it does so much. And I don't think people get how much it does.
Yeah. I mean, having good muscle mass, not only important for your musculoskeletal system and for joint pain and things like that, it takes the stress off your knees and your hips and whatever. It also helps a ton with insulin resistance. as we age and as we go through perimenopause, we tend to have changes in body composition that leads to more visceral adiposity or fat around the midline. And those changes cause issues and cause increased risk with all the things we don't want: type 2 diabetes, cardiovascular disease, heart attack, cancer even. And so muscle helps offset that. Muscle is metabolically active. So it's going to improve insulin resistance and also help as you work on the body composition changes. It's going to improve your metabolism. So help with the fat loss. Like the more muscle you have, the better your metabolism.
Right. Exactly. Yeah. That's awesome. And I love how you some people like go off on a tangent on that. So I like how you kind of condensed it and made it short and sweet, because it really is. It's complex. It's a very complex metabolic, organ. And it doesn't, most people think about muscles and they think about like working out and they think about the way you physically look. They don't think about it as an endocrine organ, something that really does signal to the rest of your body and really helps in perimenopause and menopause, because so many women are not aware of the fact that those perimenopausal changes are happening in your 30s. Nobody really, you don't talk about it. And those changes might be so slight and significant until you wake up one day in your 40s and you're like, what's happening? You're like, I'm gaining fat. Yep, I'm gaining fat and I'm irritable. And, all of these things are happening. My sleep is disrupted, right? So we've got all of these not fun things, but now we have so much information and the tools to deal with them. So that's really like, I feel like we're living in a good time to be going through this. So let's talk about, like body composition, because like before you and I talked about, like, I really hate, I don't want to say I hate scales, but the scale doesn't tell the whole picture. And we really need to be focusing on body composition and more of your lean mass rather than, the number on the scale. So if you want to talk a little bit about how you approach that and when you're working with people, what that looks like.
Yeah. So initially, I like to know what's your starting weight, but like we have to remember, you might not lose weight. You might actually gain weight. The goal here is to get you more muscle and less fat. And so we recommend, there's an at-home scale people can buy called InBody. And so we recommend that for people. Or if you can do like one of the DEXA body composition, like Fitnessity and some other companies will do that and actually tell you like, percent body fat, percent muscle mass. But the overall goal is increase your muscle mass and decrease your fat mass, especially around the middle.
Absolutely. Yeah, that's a big one, because we've been so programmed to be looking at the scale and, that's your weight. And I love that you mentioned you might actually not lose weight, because it's true. I mean, some of us, even though you look really thin, may not have a lot of muscle. So the putting on the muscle is the important piece of the puzzle there.
Yeah. And an inexpensive sort of old school way that is still pretty accurate is to just check your waist to hip ratio. What is it? Because as you get older, we tend to have a higher waist to hip ratio. You want to reverse that. Yes.
That's a good one. Yeah. It's funny. My husband and I actually got out this bad boy the other day just because we wanted to look at that. It's sitting on my desk from the other day. I was looking.
It's cheap. It's easy. Like, it's a good thing to track. So I like patients to give me their starting waist to hip ratio. And then, we can go back and look and see what kind of changes we've made. But a higher waist to hip ratio is associated with cardiovascular health and poor cardiovascular health and insulin resistance. So
yeah, exactly. And I feel like, we were talking about before, you were talking about having to weigh your protein on a scale. I, for the same reasons, am not always like keen on that. Just I'm very sensitive to if that person has had an eating disorder, if they're prone to going down that pathway, even if they haven't yet. But I think it's a good idea, metrics, being able to measure things. Like I usually only have people do it for about a week, because if you do it for a week, you can see what a portion of protein looks like, right? You can see what a portion of fat looks like. It's like all of those things. So it's like once you get it in your mind, you don't have to weigh it out anymore. But tracking your body composition in different ways is really helpful. It gives you points to actually start from. It gives you an endpoint. It gives you, different targets to hit. And then you know how to tweak things from there as well. Is there anything else that you look at when you're tracking besides waist to hip ratio or what's happening with the InBody or DEXA?
No, I mean, outside of like labs, we're looking at all the metabolic markers. So, things like insulin, fasting insulin, insulin resistance score, hemoglobin A1C, fasting blood sugar, liver function tests, because AST, ALT can show up high with things like fatty liver disease, which is really metabolic. I don't know if I mentioned fasting lipid panel. If I didn't say that out loud, we track that. So HSCRP, uric acid, so we look at those metabolic markers before and like at the 3-month mark and have some idea of, progress. And that's really the end goal here is like, we want to be insulin sensitive. We want to have low triglyceride levels. We don't want high blood sugar. Like that's super oxidative. And, when we talk about lipids or LDL cholesterol, I'm like, honestly, I'm more concerned with high blood sugar than I am with a high LDL. So like, let's work on that piece first. And ultimately, they usually both trend in the same direction. But
so is your program set up to be 3 months at first, or is 3 months just where you check in?
Yeah, 3 months is just where I check in. I mean, for me specifically, when patients start working with us, they'll sign up for either a 3 or 12-month program, but a 12-month program is really like what most patients do to see big changes. I mean, most of our patients are also, it's like, sometimes it's just, they're all different, right? Like sometimes it's just because they want to lose weight, but often it's because there's other kind of health conditions going on. I mean, that's also part of like why I shied away from weight loss for a long time is because when you address the other underlying issues, like it often comes off when we address the inflammation, it's like when you take out the super inflammatory foods, like my mom took out gluten and lost like 25 pounds, it's like, we have to address all those issues. And so typically, we're looking at the whole picture with patients, not just weight, obviously, but it's something I acknowledge at this point is like, if your goal is weight loss, I'm super excited to help you with that.
Yeah. Yeah. Awesome. So let's talk about, you touched on insulin resistance and that it seems this is what I've observed in practice for many years. The closer you get to menopause and you're not addressing your hormones, the insulin resistance piece just goes through the roof. Can you talk about that from a hormonal standpoint? Like what's happening with like the sex hormones and the thyroid and whatnot?
Yeah, it's estrogen. I mean, thyroid's important. We do get triggered to have more thyroid issues through perimenopause, menopause, just like we do postpartum. So it's always something to look at. Like if you're having trouble losing weight, but as you know, like not all people who have hypothyroidism are overweight. Like it's really they're often cold and sort of like, metabolism is a little bit slow, but they're really not all overweight. Sometimes there's dry skin, sometimes there's constipation, sometimes there's bloating, sometimes there's loose stool. It could be all over the map. So thyroid is for sure something we look at. But as we reach perimenopause and menopause and we have this decline in estrogen affects our blood sugar sensitivity. And so less estrogen means we're more likely to put on the visceral adiposity, meaning like belly fat. And we're more likely to have this trend in insulin resistance and higher blood sugar over time. I mean, I've seen it and I know you've seen it too in labs, and you have a patient who's like, she eats really well. Like, she's eating like whole food diet, eating lots of fiber, lots of vegetables. And like, you're like, why is your blood sugar off? Like, I'm just surprised sometimes that their hemoglobin A1C, but now I understand it in a different way, just from the perspective of like, oh yeah, this is called menopause or perimenopause, and estrogen it plays a big role there. I mean, all the hormones play a role, testosterone, progesterone. I mean, progesterone less so when I'm talking about like the weight loss stuff, more so when I'm talking about sleep. But yeah, the estrogen deficiency is for sure a factor.
I feel like that's a topic that's finally, again, starting to gain some traction, because I always feel like when you hear about perimenopause or menopause, you hear about progesterone. And progesterone for me did not move the needle. I do bioidenticals, and I was like, the young naive version of me is like, oh, I'm going to be all natural. I'm not going to have to do all this stuff. But then I couldn't sleep and I was super irritable and all these changes were happening. And I first added in progesterone and that did help with the sleep, but it didn't help with anything else. So I was like, what else do we have to do? And then we added in the estrogen, and that was the game changer for me. It was huge, like night and day.
I mean, I think for women who have like crazy heavy periods and stuff, like, yeah, you need some progesterone. But for me, I mean, for some people, progesterone's like a game changer for sleep and irritability. But like for me, I was more at that low estrogen state for a long time, probably. Like in retrospect, I look back and I'm like, oh yeah, probably been kind of low estrogen for a really long time. And, even if you look at like the Women's Health Initiative data, so like this big study published in 2002 that made everybody think HRT caused breast cancer, what it showed is a way decreased risk of type 2 diabetes, along with other things like decreased risk of colon cancer. But the type 2 diabetes piece is huge. Like that was pronounced in both arms of the study, the estrogen progesterone and the estrogen only arm. So, I mean, for the people listening, like the WHI was looking at conjugated equine estrogen and a synthetic progestin, which is not what we use anymore. It was almost like looking at what happens when you give almost like a birth control pill, you know, like these synthetic estrogen and progesterone. And now what we use is safer. It works better. It's body identical, you know, but nonetheless, it improves insulin sensitivity and decreases your risk for things like type 2 diabetes or just insulin resistance.
Yeah, I feel like probably 10, because I've been practicing for a really long time, 10 to 15 years ago, I feel like I would see women, because that was still like where the estrogen fear was peak. And you were seeing so many women transition into menopause and their cardiovascular risk went through the roof, right? It was like first those blood sugar changes were happening, and then they were having heart attacks and they were having, you know, also high blood pressure and all of the things happening. And now it's like we're finally trying to see, you know, we're starting to see the tides turn where people are starting to become more educated and embrace, you know, the bioidentical hormones. It's really interesting though. And I know you can speak to this too. It's like when you go to some of the functional medicine education, you know, places like IFM or A4M, we still have colleagues that are like super opposed to using estrogen or estrogen in certain forms. Like there's one person that I interviewed and she was talking about the research on oral estradiol going through liver metabolism and that being the one that actually shows the strongest benefit for people who have a high cardiovascular disease risk.
Yeah, I have heard this before. Most of the time I prescribe transdermal, but I am curious about that data because that's, I think, still a little bit controversial, you know, because you increase clotting factors and it's like.
Yeah, exactly. I'll say she doesn't do it lightly. I'll say that. Like she doesn't, most of those research papers showed 2 milligrams per day were the dose, and she will do it anywhere from 0.5 to 2. She tries to use the lowest amount to get the benefit. So I know it's like, it's a big conversation in the, you know, kind of functional and integrative medicine world on the forms of estrogen now that we're embracing estrogen. Do you use, when you do it, do you do the transdermal patch? Is that your favorite form?
Most of the time. Yeah, most of the time. I just took a course with a urologist and a sexual medicine expert. So I've really started looking more at other kinds of estradiol as well, outside of just the patch. The patch and oral progesterone has always been my go-to, but there is an estradiol ring you can use. So genitourinary syndrome of menopause is huge. And like for women who want to preserve sexual health, who want to prevent UTIs, like we need to have estrogen, vaginal estrogen, super important. And so you can use that topically. It's super low risk, but there's also like the ring, the estradiol ring that you can use, which is if you use the fem ring, it's estrogen topically to, you know, for vaginal tissue to prevent GSM, genitourinary syndrome of menopause, but it also is systemic. So it's like, I've been prescribing a little bit of that. I'll prescribe gel sometimes for people who can't use the adhesive. Yeah. But I mean, in general, I'm transdermal estrogen. Although I have a few patients who have come to me who have been on oral estrogen. I'm not opposed to keeping them on it if they've been doing well. It's like the first year of initiation where it's like a little bit higher risk. But I think that little bit higher risk is also like really little bit. And just for anybody listening, like looking at the literature is so complicated because when we look at the data, like most of the data we talk about comes from the WHI, which was using conjugated equine estrogen, which is it's not actually synthetic. It's not synthetic because it comes from a horse's urine, but it is not body identical to a human. Body identical to a horse, right?
To a horse. Yeah, right. I know. That's like us doing studies to determine what's going to.
And then you've got the progestin, which, yeah, kind of complicates things. I mean, it's like if we were to study blood pressure medicine and we're like, all the blood pressure medicine does this. And you're like, well, it's like a beta blocker and hydrochlorothiazide work totally differently.
Yep, exactly. Yeah, it is very complicated. I still feel like in general, in the realm of research, there just hasn't been a lot of good research done on women in general and women's specific issues. But we look back retrospectively at all of this information and it's like, yeah, what what truth can you glean from it? There's not a lot. We need to do a lot more current relevant research. That's a very, very big thing. Awesome. Yeah. And I love the oral progesterone because, I was one who like did the topical for a really long time. And I was like, I think I actually have to put like a whole bottle on myself to actually get a benefit. So I'm going to do the oral because it's that. And then worried about like,
I used to recommend it and now I'm like, forget it. Just use the oral progesterone. Like it works great.
It's easy and it's cheap. It's not an expensive, medication. So it's like, it's super easy. And for those of us who are moms, I'm always concerned about like transfer to kids and like, how long is it taking for your kid to absorb? I mean, to absorbing your skin. It's crazy stuff. Awesome. So while we're talking on the, kind of the idea of hormones, before we got on, we talked about microdosing the GLP-1s. And so for those of you who are not familiar with the GLP-1s, I'm going to let her give you guys a little overview of what they are and how, when you microdose, it's different than the dose that you're giving to somebody who has metabolic issues.
Yeah. And talk about the research. Like we don't really have it. So let's just be like right up, like clear from we have research on high dose, which I just have to like bring this analogy back to like testosterone too. Like if we give a woman testosterone, we actually have research on giving people really high doses. And what happens, those are people who are transgender, who are transitioning from female to male. They get these very high doses of testosterone. So we actually do have that data. So I think with the same thing and like with GLP-1s, we have this data for what happens when we give people really high doses. And those are morbidly obese diabetics and, what might happen. So when you go so traditional GLP-1s are things like Ozempic and Wegovy, and they're FDA approved for obesity and diabetes, type 2 diabetes. However, sometimes you have somebody who has some insulin resistance. She's not morbidly obese and she doesn't have diabetes. Can we use it preventatively? What happens if we use it at a really low dose? Can we reduce the side effects? And we can definitely reduce the side effects. I mean, I can say from seeing this clinically, people who go on a full dose of those medications often do experience a lot of side effects, namely nausea, appetite suppression, they won't eat. But if you use a really, really, really little dose, they still have benefit without as many side effects. And so they're just better tolerated. I do counsel patients, like when you start this, we can work on titrating the dose up slowly. If you experience appetite suppression, food aversions, nausea, gastrointestinal side effects, we should back off the dose. The other thing to watch for is I tell people don't watch your fat intake because it can increase your risk of gallbladder disease. So don't eat a bunch of potato chips. I mean, it's really important I also have a kind of sort of requirement in our clinic. If we're going to start these medications, you have to build muscle, because if you don't work on building muscle and you're not in the routine of lifting weights, lifting heavy weights, not like a 5-pound weight, but getting into lifting heavy. That's I always encourage this first, start first with lifestyle. That's not what I jump to, right? But start first with lifestyle, lift weights, eat a lot of protein. Once you can do those things, we can layer in a GLP-1 at a really low dose, I think safely, but that's where tracking the protein can be helpful and eyeballing it, or at least making sure every meal you're getting at least bare minimum, 30 grams of protein, especially in the morning meal. Yeah. But I mean, I think in general, they're really well tolerated. We have a lot of patients do really well on them. Yeah.
Not only that, but it, on a cellular level, I've even seen people who post-COVID or long haulers or other kind of non-traditional uses of those medications, it really is helping change the, cell function. And that's something that I probably beat like a dead horse. My patients probably get sick of it because I'm always talking about, I'm like, the cell is the key. I'm like, if you don't have fluid cell membranes and you can't get your nutrients in and out of the cell and oxygen into the cell, it's like everything else we're doing is a moot point. We need to get the cells healthy. So that's another place where I think we're seeing it too, is just improving cellular health.
Yeah, I mean, it's being used for psoriasis and fatty liver disease. And I mean, there's a lot of indications for it. Well, I should say there's not a lot of indications for it. There's a lot of people using it clinically in practice and seeing improvements. It's just not approved for all those things. But we use things off label all the time, testosterone for women is used off label.
Yep. Speaking of testosterone, do you tend to use a lot of testosterone, or are you using more of like estrogen and progesterone first?
I start with estrogen and progesterone first, and then I layer in testosterone when women need it. I always say like measure testosterone because we don't always need it. Like not every woman needs it. You know, sometimes people's testosterone is fine and they feel great once they start estrogen and progesterone. And some people don't tolerate testosterone, they get, hair loss or acne. It's not as common, but yeah, I layered in kind of one thing at a time. I don't like to start all like 5, like thyroid, estrogen, progesterone, testosterone, GLP-1. Like let's take it one step at a time and like see how, it's a lot.
I know. I'm always suspicious of that.
Which is why a 3-month program is like not enough.
Yeah, truly. It's truly when you're making, I always feel like this is like radical lifestyle change, right? It's like we talked about, like talking about the mindset, like getting mindset and intention and all of that dialed in, and then working on your diet and working on exercise and prioritizing sleep. That takes time. Like you can't do that overnight. Very rare. Every once in a while, I come across a person who's like, okay, I'm doing this and it's done like tomorrow, but that's like 0.001% of the population. Most of us can't do that, right? So it's a process. So yeah, 3 months is not a lot of time. It's like you can lay the foundation, but you need to keep going. You need to keep building on that foundation. And
I think it's important too for people to give themselves a lot of grace. Like when I first started kind of changing my diet over, I don't know, I'm not like I don't have to be really rigid with myself. I'm just not. I've never been super rigid about, I don't know, alcohol is a good example. Somebody asked me the other day, do you drink? And I'm like, if I want to, which the answer is no, not really. I don't want to because it makes me feel like crap and my Oura Ring data goes to hell. And like, I just worked out. Like, why am I going to like screw myself over with a glass of wine that doesn't even help me in any way, But nonetheless, like if I wanted to have a glass of champagne while in Paris, I might. Like, I don't have any rigid rules, right? So I don't know. Everybody's different. Some people need that. Some people don't. But I think the whole point of this, like aside, is be gentle with yourself, move the needle in the right direction. Don't expect perfection. Just sort of like build on habits one thing at a time. And, eventually things change, but give yourself time.
Yeah. My mantra with all the people I work with is progress over perfection. Because I think so many of us are programmed, right? Perfectionism
like, progress
is a
over
trauma
perfection.
Response, right? Yeah.
Yes. Progress over perfection. And I'm like, small changes in the right direction add up over time. My patients know I say this all the time.
They do. They really do. It's like you don't even have to take a full step. Like one baby step, in front of the other every day adds up. And it's like, so we're so programmed to like want everything, especially now. We want everything like yesterday. We want all the benefits. And it's like, that does not happen with our bodies. It took our bodies a really, really long time to get to this place. And it's going to take our bodies a long time to get out. And so it's like, yeah, giving yourself grace is absolutely huge because it's like, it's so interesting. One of the whole reasons I started like focusing on working with moms was because in my practice, it's like family practice. It's moms and kids. And the moms they would go on vacation or a holiday would happen and they would get their kids back on track on their plans and then they themselves would not. And it was so fascinating to me. I'm like, why is this happening? And it's like, because they're prioritizing their kids and their kids' health over their own, and like, they're not, there's all the, mindset. I'm not good enough. I'm not worthy. I don't deserve it. All of those things. So it's like getting beyond all of that.
Yeah, totally. I love the worthiness talk. Like you're worth it. What is your worthiness? And I love really like drilling down to like what's under there.
Yeah. Oh, we talk about that a lot. That's what like spurred me on my, it's funny how like a lot of us who are in functional medicine, integrative medicine, it's a lifelong learning process. Like you can't ever really stop learning. And like you said, you're just working with the urologist. And like for me, like I like dove headfirst into like trauma and emotions and mindset and all of that. So all of my like certifications and education in that in the last like 5-6 years have come in that realm. So, and that's something that I do a lot with because it's
awesome.
Doing that a lot.
I got to learn more about that because that's new. That's sort of like my new jam in the last several years too. It's like, and it's part of why I'm here doing what I'm doing now. It's like I started with that. But not so much in the patient realm, just more in the personal realm.
Yeah. Mine transitioned from personal to patient.
It's like mold trauma. And then you're like, I got to address this.
Yeah. Yeah. That's exactly what happened for me. It was like, I had the aha moment for myself like 12 years ago. I literally like sat up in bed one day and I was like, the change has to come from within me, not anywhere else. So it was like, I knew that I had stuff I had to work on, and I did it for myself. And then I started noticing that all of my patients who said they did that kind of work, inner work, whatever it was, whether it was like talk therapy or EMDR or any of the myriad of things out there right now, like they were the ones who did better. And I was like, there's something to this. So that's like why I started incorporating it into practice too, because it's huge, such a huge piece of the puzzle.
It's so huge. It's so huge. And I told, like, this is one of the things I talk about a lot is like stress. I used to think like stress is the straw that breaks the camel's back. And now I'm like, no, that like childhood conditioning sets us up for things like autoimmune disease and cancer. I mean, it just does. Like, look at Gabor Mate's work. That's where I send my patients a lot of times. So yes, a lot of times in our new patient visit, I'm like, tell me about your childhood. What was your personality like? And I'll say like 95%, literally 95% of my patients are like super high achievers, were really capable when they were children because they often put their own sort of needs on the back burner, or they had to put their own needs. Nobody was there. Like they didn't have their emotional needs met. It usually wasn't like big trauma, big T trauma. It was like some little trauma. Their emotional needs were maybe not met. They were, the oldest and had to take care of other siblings, or one of their siblings was like severely disabled and they had to like really show up and sort of fend for themselves. Whatever it is, that is definitely the trend. And then they end up as these like high achieving sort of badass women who it's not so obvious all the time, but they're like, their needs are sort of on a back burner. And I can relate because I'm that person too. Like, I'm like, oh, I know you. Yeah. We're cut from the same cloth. Why are we all here in the same room though?
Exactly. It's that is the truth. One of the I think when I recorded like the first 5 podcasts, that was one that I did. I talked about from like 0, like, basically conception to the age of 5, those are the critical years. And then everything else is built on that. And what you said is so true. It's like 95% of the women we work with are in that realm. They're accomplished, they're high achievers. It's a trauma response.
Yeah, they're super capable. Like everybody goes to them because they're like, I know if I have you do this, it's going to get done right.
Yeah. Do you even I even think back to like being in school, like when we were in school and you'd have to do projects, everyone would want to work with me because they knew that I would get it done and I would do it right. And I wouldn't, be like I hate to say the guys in the corner, but it was always like, there was always this like group of guys who were like, oh, I don't want to do it. I'm going to work with her because I know she'll do it. It's like they didn't want to nobody wanted to partner with them. So it's like, it was really interesting when I looked back and I was like, yeah, I have been the go-to person for so long. And I'm like, now I need to be the go-to person for myself.
For me. Yeah. It's just like back to show up for yourself. Like I've been showing up for everybody else for like 40 years. I'm like, what the hell?
I know, right? I know. And being the oldest definitely adds a layer on that.
I'm going to the gym for an hour. Like what?
Yeah, exactly.
And I'm going to make myself some chicken. But I think it's
exactly.
It really, I think for me, this whole process has been transformative, not just in the physical body and feeling more confident and sexy and whatever, but it's like really realizing like, oh, that's what that looks like to show up for yourself. And damn, that feels good. Like, all right, I'm going to do more of that. And I think it influences people in lots of different ways. And just like, when you work with moms, it's like, it's cool because you get to influence their whole family and then the whole family gets healthier. And like, if mom can, sleep better and she feels better, all those things, we know this. But I think it's, it's like the same way when you help her feel more like herself, when you help her feel more radiant, when you help her feel more confident and, she shows up for herself. I think the family sort of sees this like, and especially your daughters, they see like a different kind of way to be.
Yeah. That's a big thing with me. It's like, how am I showing up for my daughter? What am I modeling? How am I speaking? How am I acting? All of those things. And it's funny because like, if I do something, I'm not we all have bad days, right? And if I have a bad day and I like snap at them or something like that, I apologize because I'm like, I did not mean that. I'm like, I tell them, I'm like, I'm having a bad day. I'm like, I'm sorry that I, stepped at you or whatever it is. It's like that. And like, that would have been unheard of for our parents to do. It's like, it's crazy. But yeah, I mean, it's like trying to model what I want her to have when she's older because, life was different. Life was different for us. So I would love for you to share if a woman is like in that contemplation state and she wants to start this journey, what's the first thing you would recommend that she do?
Mindset. I think sort of mindset and get clear on like, what are your goals and why? Like, what's your why? What are you trying to achieve here? Is it because like, for me, actually, we haven't even talked about this, but for me, my why was I was having migraines, and it turned out that I have a herniated disc in my cervical spine that I found on a Pronovo MRI. And so I started going to physical therapy and, eventually like got an MRI. I'm married to a spine surgeon. I mean, basically like what you need to do is strengthen your upper back muscles and strengthen your lats and serratus anterior and all these things. And so I realized like, oh, damn, I mean, I'm not going to have surgery on my neck. Like I'm going to do everything I can to avoid that. Right. And also these headaches are really annoying. Like I got to figure something out. And so I started lifting weights, and then it just sort of progressed from there. So I think like for me, it was like, I want to be able to do whatever I want. Like I like to go outside and ski and wakeboard and, like I'm pretty stinking active, and I have no intention of stopping that at any point in my life. When I get to be older, I want to be able to do all those fun things. And also my husband is a freaking animal, and I'll want to keep up with him to some degree, like I'm not going to be like, I can't go hike with you or ski with you or something like that because my neck or because I don't have muscles, So for me, it was really like, that was my why, but then it morphed into something else. So I think the first thing to do is just like figure out what is your why. Sit down and really think about it. Like, what's the why? And then from there, you've got like, okay, yeah, the honest why, like get really honest with yourself, and then picture yourself. Like what would look differently for you in your life if you were stronger, if you had more muscles, if you had a great metabolism? Like, how does it feel? What activities do you do? What are your relationships like? Do relationships change? What are stresses like? All that kind of stuff. So I think really just like getting your head around that mindset piece, what you want to achieve and why, and then you start. But everybody needs like to, and it's different for everybody. Like we see in health, it's like people, sometimes they come see me because they're like, I am losing hair. And like, that is the straw that broke the camel's back. This is not acceptable. Like they were okay with having a hemoglobin A1C of 6. But once they started losing hair for a lot of women, it's like, all right, that's not going to fly anymore. So, I mean, for some people, it's just like, they don't sleep as well, or their relationships are not as good because they're irritable or whatever it might be. We all have our different kind of challenges and our different why, but I think it's important to identify that.
Yeah, exactly. Mine was kind of similar. I was having headaches and it was hormonal. It's interesting that you had a herniated disc at C7. Do you have any idea where it might have happened?
It's 4 or 5, I think. 4 or 5 and 5, 6.
Oh,
no, and I don't, which is really bizarre. I have no idea. Like I didn't have any like significant injuries that I can remember. I mean, as I've always been like active, and who knows?
I know. I think if you're active, there's so many things.
Oh yeah. Yeah. I mean, at some point something changed, and I've been getting these. I think 2023, I was like, I gotta figure out what these are from. Like what's going on here? And so I went down this like journey of trying to figure out like, where is this coming from? And then, then it was like 2024. I was like, I'm going to get fit. And now, it's like every year I sort of have this goal, but
it evolves.
Yeah, it evolves.
Yeah, it is. And it's important because I always bring this up to people. I'm like, this isn't something that really has an endpoint. I'm like, it's a journey. Your health and your life are an evolution and a journey. So it's like, there are going to be some changes. There are going to be some ups and downs. And it's like, what we're doing truly is building resilience. We're building emotional and physical resilience, and so the more resilience you have, the better you are going to be when you weather these storms. It's like, it's interesting. It's like that is what we're doing. We're literally trying to build a resilient foundation so that we have longevity and we can do the things we want to do in life and later in life. And it's like, I want to see my kids grow up and I want to see them have kids and I want to see all of those things. And I also have a husband who's like yours, who's like beast and can do anything and is better than everybody at everything and like fast. Like when we're snowboarding, he's like the first one down the mountain and I'm like, I'll never be as fast as him just because I'm much more cautious. I had one time we were snowboarding and I hit my head and I didn't totally black out, but I had like a brownout moment. And I was just like, yeah, it was like, I want to say like 6 or 7 years ago. So I'm just like, I'm super cautious now. Instead of bombing down, I'm like, let's do some nice big S turns and get down upright and with a solid head. So yeah, I mean, I want to be able to do all that stuff too still. I want to be able to go hiking and do all the things that we do. If just so the audience knows, Christine also lives in Colorado too. So we have a lot of opportunity for outdoor activity and outdoor recreation here. So awesome. So that's great. I agree with mindset being a really good place to start. One other piece I wanted to ask you about was if a woman is in the program or just, working on all of this stuff and she is not seeing the progress that you think she should be making and she thinks she should be making, even though she's following what you're doing. What are you looking at next? Like, what are your next thoughts?
I mean, that's always where I'm like stepping back. Like, are we missing something? Like this happens with Hashimoto's, if you're like, your antibodies aren't coming down, we don't see improvement. Like, what are we missing? Is there something else here going on? Like mold toxicity or heavy metals or like Lyme, what else are we missing? And so I think we generally kind of evaluate all that stuff at the onset and get like a really good picture of somebody's health, but they don't always do all the testing, So yeah, I mean, generally I would stay there. I think the other important piece is like, we got to look at the nutritional piece. Like I find a lot of women, I would say most of my women who are in menopause, who are struggling with weight, are restricting food a lot because they're like, I can't eat like I used to eat. If I do, I'm going to be overweight and I'm not going to let that happen. So I don't eat that much. And so I have to go through that with them and really sort of restructure their relationship with food to some degree where it's like, okay, your metabolism needs to see that you're safe and you can eat food. I eat more food than I used to eat. And that's how you really like condition your metabolism to say like, oh, I'm safe. Like I got to keep going, burn the things off. Like that doesn't mean eat potato chips and like, I don't know. Actually, what I've learned through this journey is like, I was eating a really high fat and it was all healthy fat, but I was eating a lot of fat. And, fat has calories and I'm by no means low fat, but I think for a lot of women, what I end up doing is sort of flipping like, okay, first priority is protein. Like eat a lot of protein. Most of my patients are not eating like heavily processed foods and drinking Diet Coke and things that would mess with their satiety and their signaling. But some of it too around food is like sit down, really mindfully eat your food, chew your food. Try not to be on like social media, eat 3 meals a day. Like we have a lot of recommendations around nutrition and that sort of thing, but it really is something we usually do up front. But nonetheless, it's like really focus on protein. With carbs, think of carbs as fiber. So like high fiber carbs, I eat rice and potatoes and fruit. I'm not like occasionally I might have some gluten-free pasta. I just don't have that much of it. Like, this much gluten-free pasta or this much potatoes, it's like a really tiny amount or a really big amount of potatoes. So, generally I think working around that can be helpful. And then sometimes it's like really looking at like, what's the diet really look like? I think this is where I think there is a time and place for that 1 week of tracking and like, let's figure out, I don't do this with everybody, certainly not with people who have disordered eating or, teetering on that. But, if I have somebody who's in a spot where she can do that in a healthy way, it's like, okay, let's track your food. Let's see what you're actually eating here. And then take another look at like, how do we need to adjust this? I mean, the reality is if you do want to lose weight, you should be to some degree of a calorie deficit, but you also, it's like this trick where you have to remind your body, like, I've got enough food. I got to burn food. I got to burn fuel your body, focus on protein. And yeah, so tracking can, I think, teach us a lot actually.
Yeah. Speaking of tracking, do you ever have people use like a CGM or for people who don't know, it's a continuous glucose monitor.
Totally.
Okay.
Yeah.
Are you using them a lot?
One of the first things we do. Yeah. I mean, generally I'll meet with the patient and then they'll meet with my nutritionist. She'll go through all that stuff I just talked about, talk about sleep, stress, lifestyle stuff, and we'll get patients started with a CGM. So continuous glucometer, so they can really like focus on that. Yeah, totally.
Because I feel like it can also show if you're having an inflammatory response to healthy foods too, which was one of the things that I have found most interesting is like persons like, oh, I just ate, broccoli, or I ate sweet potatoes and my insulin spiked. I mean, with, it's really, I just think it's so interesting. I think that is one of our most valuable tools. Like it's super, super interesting. So you are tracking that too as well. That's cool. Okay.
Yeah. And it is interesting. That's sort of like, that was my first sort of like dive into this world, was because I had gestational diabetes. And so we didn't have continuous glucometer back then, but I was very determined in my first pregnancy. There was no way you were going to put me on medication when I was pregnant. And I monitored my blood sugar 4 times a day for like 9 months. Maybe not 9 months, but whenever I found out about this diagnosis, and it was like surprising because didn't have any of the traditional risk factors around that, but I learned a lot. And wow, that Ezekiel bread I was eating was really spiking my blood sugar. And, later I'm like, oh, I'm super gluten intolerant. Like I can't do gluten. It does not work with me. Yeah. And that's probably why, right? It's like was causing a lot of inflammation.
Did you know about your Hashimoto's at that point, or was your Hashimoto's diagnosis after that?
No, I didn't have it then. I don't think. Yeah. I don't know that I had it back then. I think the Hashimoto's was probably triggered from mold. Maybe it was triggered postpartum because, autoimmune stuff happens postpartum. And my oldest daughter's 13 years old. So 13, 14 years ago, I just like thyroid was on my radar. I was like checking TSH. But if I've gone back and looked and I can see my TSH was like maybe around 2.5 or 3, like, which is too high when you're trying to conceive and have a baby. But there was nothing like super obvious or overt at that time. But, as it goes, like regular doctors don't usually check those antibodies. I have a family history of it. So I was, honestly, I don't even remember. Was I asking to check it back then? I don't know. Probably not.
Yeah. So who in your family, is it like first degree relatives that have Hashimoto's?
Oh, yeah. Yeah. My sister has Hashimoto's and my other sister has Graves' disease.
Yeah. It's really interesting. I find I've got a couple of families that have the prevalence. It's like, it's really interesting. The difference between people who have like the family history of Hashimoto's versus people who get it, and don't really have the family history. The family history people I take with, when I get them into my practice, I handle very differently because the likelihood seems like it's so much greater, with all of the root causes, with those people end up manifesting it if you don't catch it before and start doing all the things before. My husband's family is like that too. Like everybody, he has it. His sister, all of his mom, like they all have it. It's kind of crazy. It's really interesting. And then, like I said, I've got a couple of families. I've got one mama who has it, and she's got 7 kiddos. And when I started working with them, the older ones were in their late teens and early 20s, and they have all the way down. Her youngest one now is, I want to say 11 or 9. And the older ones had already been diagnosed, but like we've been trying to prevent the diagnosis in the younger ones. So it's like, it's really interesting to look back at all this. And like, I love that, like you've kind of watched yourself over time, because I've done the same thing too. And every once in a while I'll go back and like look at my labs from like 15 years ago. And I'm like, oh my gosh, I'm like, I can see where certain changes started happening. And then,
now that you know what you know, you're like, oh,
I would have done something differently, completely differently, right? Awesome. So last question I wanted to ask you was, if you were on a desert island and stranded, and you only had 3 things you could bring with you, and this is not people, like obviously we'll say the given is our family with us, things, objects or things that would support your life, what would you have with you?
Oh my gosh. Seriously, this is like such a hard question. I mean, my cell phone, like, so I could call somebody and get some food. Oh my gosh. What would I bring with me? Like, this is a hard question. I would bring, actually I have a real answer to this question. So we had a huge fire in my neighborhood. So I live just outside of Boulder. And this was like 2 years ago, or maybe 2.5 years ago. And there was that huge fire, which was like crazy because I live in the suburbs. I'm not up against the foothills. I was in my office and saw this like crazy cloud. And I called my friend who's married to a firefighter. And I was like, do you know what's going on? Like, it looks like there's a fire. And she said, yeah, Billy said we should be evacuating. You should leave your house right now. And I was like, what are you talking about? And my kids weren't home. My very awesome babysitter like saw some stuff and she brought them to my parents' house out in Erie. So literally I brought my contacts. So 100% my contacts, my contact lenses, and my thyroid medication and my nut pods because I really like coffee and I don't do dairy. And so I'm like, I'm good. I got nut pods and contacts and my thyroid meds. Like, we're good. And I went to my parents' house. So I guess that's my answer.
That's awesome. No, I love that. I know those kind of questions make you think, right? Because like occasionally I'll be interviewed on a podcast and they'll ask you something like that. And I'm like, what would I do? That's for me. I'm like yeah. Oh, me too. I have to wear my contacts or glasses. Yeah. My hormones are coming with me. But I like the coffee, the nut pods. That's awesome.
I mean, the nut pods is just ridiculous. I'm like, for real? I didn't actually think it was going to get that close to the home. It's like,
I know. That was a crazy thing that happened.
I don't know, photos. I bring my photos, my kids' photos when they were little.
But you know what? We've got them on our phone mostly now, right?
I know. I mean, I told you my phone, I'm going to bring my phone and my contacts and my hormones. That's it. Nut pods are getting left behind.
I know, right? I know. Exactly. Oh, awesome.
I can live without coffee for a minute, but I don't like to.
I know. Neither do I. Oh, gosh. Well, let me ask you one more thing. So when you're working with women, do you make them get off of coffee? Because so many practitioners do, and I don't anymore. I don't either.
No, I do not. I am like, if they're super anxious and are having a really hard time, I recommend that they eat before they drink coffee because just like alcohol, if you have alcohol on an empty stomach, it's going to make you drunk. Like if you have coffee on an empty stomach, it's going to give you that caffeine buzz. It might contribute to some anxiety. So there are some times when I'm like, hey, I might want to like cut back or, switch to tea or something like that. But that is definitely not my rule by any means. I think usually it's like eat more food and eat breakfast and stop fasting is what I'm usually telling women. Eat breakfast, stop fasting. You can have your coffee. I tell people that I can take away gluten. Like you can ask me to be gluten-free. I'm fine. Dairy, fine. But do not take away my coffee. Come on.
Yeah, same. Same. Totally. I love that. Oh, but thank you so much. I know it is. I just like it. I like the warmth. I like the ritual of it, the warmth. There's so many things I love about it. It's awesome. Well, thank you so much for sharing everything with the audience. And is there a place that if they're looking to work with you or want to know more about you, where they can find you?
Yeah, my website's a great place to start. It's drchristinemaren.com. So Dr. Christine, and then Maren's like Karen with an M. And I am pretty active on Instagram. So you'll find me in my face and whatever I'm doing there. But yeah, website's a good place to start.
And then is there anything that you would like to share with the audience, like a free gift or anything?
Yeah, we have a free gift. So it's 12 ways to detox your home. And really the goal being like better hormone health. We didn't talk about this much, but endocrine disrupting chemicals can definitely affect hormones, can lead to early menopause, for infertility issues, across the board. And so I have a 12-month guide to sort of how to clean up your home, all the products that I use at home. Progress over perfection. That's a big of that book is like, one step at a time, progress over perfection. You don't have to be perfect, but the things you do every day do matter.
Awesome. Yay. Thank you so much. And again, just thank you so much for being on here. Awesome. If you made it this far, I truly appreciate you. Remember, knowledge is just the beginning. Taking action is what truly sparks change. If you're overwhelmed and don't have enough energy to make it through the day, I invite you to book a free 20-minute coaching call with me. It's a no obligation chat where we can discuss your health goals and how I might be able to help you achieve them. Visit the link in the episode description to book that call. Until next time, keep striving for wellness and remember, you have the power to not just survive, but thrive in motherhood.